Hello, everybody. Welcome to the second in our series of webinars for medical undergraduates during the lockdown as a result of the COVID crisis. Today, we have Mr. Stephen Boyce, consultant colorectal surgeon, who will be taking you through the management of intestinal obstruction. Mr. Boyce trained predominantly in Edinburgh and later in Brisbane, Australia, but chose the warmer climes of Oxford, UK to live and work in. I'm sure he has a wealth of knowledge to share with you and will be taking questions after. Do use the Q&A option, which I will monitor for your questions. Over to you, Stephen.
Okay, thank you very much, Mike. Thank you, everybody, for joining us this afternoon. So we've got about 20 minutes or so to talk about signs, symptoms, and management of intestinal obstruction. Okay, so we'll start off with some terminology. What exactly is intestinal or bowel obstruction? So the term bowel obstruction refers to a physical blockage of the bowel, where there is a structural pathology which physically blocks the passage of intestinal contents. So when a bowel segment has become occluded, there's then consequently gross dilatation of the proximal limb of the bowel above the obstruction. This results in an increased peristalsis of the bowel, which leads to tinkling bowel sounds, which we can hear in auscultation. It also leads to secretion of large volumes of electrolyte-rich secretions into the bowel. This is known as third spacing. So we lose a lot of fluid into the bowel, into the wall of the bowel, through bowel wall edema, and also sometimes into the peritoneal cavity. So this leads to massive fluid shifts, which is responsible for dehydration, for renal failure, which is common in these patients. So what is not bowel obstruction? So the symptoms of bowel obstruction can occur when there's no physical blockage to the bowel, but the bowel is not working properly. And we most commonly see this as a consequence of what's called postoperative ileus. So the patient might be distended, might be vomiting, but there's no physical obstruction to the bowel, but the bowel is not peristalsing normally. And most commonly, as I say, we see this in the postoperative patient. This is a functional obstruction, or what's called a paralytic ileus, but importantly, there's no mechanical obstruction. And that's important because paralytic ileus always settles with conservative treatment, and mechanical obstruction often needs surgery. So it is possible to differentiate paralytic ileus from a mechanical obstruction through the clinical setting, for example, in the postoperative patient. But if necessary, sometimes we do CT our postoperative patients if they're worried that they have a mechanical obstruction. So what is a volvulus? So volvulus is a cause of intestinal obstruction, and a volvulus is a twisting of a segment of the intestine causing a bowel obstruction. And we see this both in the small bowel, and we also see it in the large bowel. So importantly, as well as the bowel itself twisting, the mesentery, which supplies the blood to this section of the bowel, can also twist. And if the mesentery becomes obstructed and the bowel and the vessels become obstructed, this will predispose to ischemia, hence the coloration here in this diagram, and infarction of the bowel, which is a very poor outcome. So another word that we hear sometimes in describing or looking at the causes of intestinal obstruction is an intussusception. So with intussusception, this is a laparoscopy picture. We can see that the intussusceptum is invaginating into the most distal part of the small bowel. And this is common in children and sometimes in older patients where they have tumours. The tumour is treated as a bolus inside the lumen of the intestine, and it's peristalsed down to the distal part of the limb, this distal part of the intestine, and this can cause an intestinal obstruction. So one part of the segment telescopes or invaginates into the next segment. So what is a closed loop obstruction? This is a finding sometimes that you'll see on CT scans, and it's important because this is an indication that often prompt or immediate surgery is required. So a closed loop refers to a section of intestine which is blocked at 2 points. So if you had a single point obstruction, say midway along the small bowel, then the proximal small bowel could fill with fluid and decompress through the stomach, either through vomiting or nasogastric tube. But in this example, you can see it, there's an adhesion across this loop of small bowel, and so then the bowel is blocked in 2 points. So there's nowhere for the intestinal content to escape, and that segment gets bigger and bigger in size until it infarcts. So we see this sometimes in small bowel obstruction. We also see it in large bowel obstruction. So in large bowel obstruction, if there's an obstruction at the level of the sigmoid, most commonly a cancer, and the ileocecal valve is competent, this means that fluid can't escape from the colon, either distally through the rectum or proximally back up into the small bowel, and that in effect is a closed loop. So a closed loop obstruction requires emergency treatment because the bowel cannot be decompressed proximally, and in a closed loop there's an increased risk of ischemia and then bowel perforation, which can be catastrophic. So why is it important that we know about intestinal obstruction? Well, it is an important cause of morbidity and also mortality. So there was a national audit of small bowel obstruction only 2-3 years ago, and it said that it accounted for 12,000 operations in England and Wales in a year. Morbidity was high. Acute kidney injury occurred in 20% of those admissions. There were high readmission rates when people were conservatively managed. Often they were readmitted. And overall mortality for all of those people admitted was 8%. So to give you an example, our mortality for major colorectal surgery performed electively in Oxford is just less than 1%. And the post-operative mortality rates was 15%. So high cause of morbidity, high cause of readmission rates, and frightening post-op mortality rates. So what are the signs and what are the symptoms? So the symptoms are predominantly of colicky diffuse abdominal pain, vomiting, and abdominal distension, and absolute constipation. So by absolute constipation, I mean no passage of flatus or stool from the bottom. If people develop complications of intestinal obstruction, they might develop fever and systemic upset. So when we're thinking about a patient who may be presenting with intestinal obstruction with these symptoms of distension, vomiting, pain, and constipation, we need to think, could this be small bowel obstruction or could it be large bowel obstruction? And this is something you should really be thinking about from the moment that you see the patient, because the causes are very different and the treatments are very different. So the junction obviously between the small bowel and the large bowel is the ileocecal valve. So we need to start thinking immediately, is the obstruction proximal to the ileocecal valve or distal to the ileocecal valve? So when we're talking about causes, essentially there are common causes and uncommon causes. When we're talking about small bowel obstruction, the common causes to remember, which account for over 90% of cases, are adhesions or hernias. So adhesions are essentially sticky bits of scar tissue that form between loops of intestine and the small bowel as a consequence of surgery. And hernias, I think we all know what hernias are. The abnormal protrusion of small bowel from one body viscus to another. So when we talk about obstruction to the lumen of any structure, whether that be small bowel, large bowel, ureter, esophagus, it is helpful to think about extramural causes, mural causes, and interluminal causes. So by extramural, I mean outside of the bowel, causing an obstruction of the bowel, and typically these are hernias and adhesions. Peritoneal metastasis from cancer such as ovarian cancer, or small bowel volvulus, which we've already mentioned. Causes within the bowel wall itself, which can cause obstruction of the small bowel, are rare. So they're rare. Small bowel tumours, we see 1 or 2 cases a year, where large bowel cancers we see probably 400. Inflammatory strictures normally occur in the background of inflammatory bowel disease, such as Crohn's, intussusception of the small bowel, Meckel's diverticulum. So these are uncommon causes. Interluminal causes mean something inside the lumen of the bowel which blocks it. Gallstone ileus, this is a picture of gallstone ileus on the right of the screen. The top picture, you can see the small bowel is obstructed because it's dilated proximally in the surgeon's left hand and collapsed distally, and there's a big stone sitting in the middle, which he then consequently takes out through an enterotomy. But gallstone ileus is uncommon. Maybe we see 1 or 2 cases a year. So take-home message from this slide, small bowel obstruction is usually due to adhesions or to hernias. So large bowel obstruction, the commonest causes are colorectal cancer or volvulus of the sigmoid colon. So that's the take-home message. So if we consider the same classification of extramural, mural, and interluminal, extramural obstruction causes in the large bowel includes volvulus. Hernias can happen as the sigmoid in particular can herniate through the left inguinal region. Peritoneal metastasis, uncommon, more common in small bowel obstruction. Mural causes is colorectal cancer, benign strictures such as chronic diverticular disease, and intussusception, which again is usually secondary to tumor intussuscepting, and intraluminal. So intraluminal, sometimes people can have horrible fecal impaction. They're not usually completely obstructed, but they have very obstructive symptoms. So take-home message from this slide: common causes of large bowel obstruction, colorectal cancer, or volvulus. So this picture on the right is a sigmoid volvulus, and it can be absolutely massive. When you perform a laparotomy in these people, this thing pops out of their tummy like a spare tire. So when we're talking about history and examination, which are relevant to intestinal obstruction, we're thinking immediately, what is the potential cause? Is this a small bowel obstruction? Is this a large bowel obstruction? And are there complications from the obstruction, which means they need urgent surgery? So in the history, the pertinent things will be, have they had previous surgery? If they've had previous surgery, the likelihood is they have a small bowel obstruction from adhesions. Are there systemic symptoms such as weight loss, a long history, which may point you towards malignancy as being the cause? And what's the nature of the pain in their tummy? If this is intestinal obstruction and it is uncomplicated, we would expect the abdominal pain to be colicky and diffuse across their abdomen. If the patient consequently develops constant abdominal pain, we're worried that they've developed complications such as ischemia and perforation, which will cause peritoneal inflammation, which will be sore when they move and be localized to one or two quadrants. So when we examine the patient, we need to assess them for dehydration. Dehydration and renal failure are common. We need to look for scars. Have they had surgery, which gives a pointer towards adhesions as a cause for their obstruction. Never miss a hernia. It's extremely embarrassing when you present a case of small bowel obstruction and your boss says to you, do they have a hernia? And you say very confidently, no. And the boss then exactly demonstrates a small femoral hernia. So the typical story will be a lady admitted maybe under the physicians, but treated as diarrhea and vomiting, but no diarrhea. The predominant symptom is vomiting. And eventually after 3 days of symptoms, they have a CT scan and the radiologist diagnoses a hernia, which is deeply embarrassing. So always look for hernia. They can be small, they can be subtle, they can be the size of your little pinky. So always look in the groins. Look for abdominal tenderness. If the patient is tender, we worry that they're developing ischemia. Look for systemic upset. Are they tachycardic? Are they febrile? Are they dehydrated? And I do think it is helpful to listen for bowel sounds, those tinkling bowel sounds, to let us know that the patient's got increased peristalsis proximally. So this picture on the right is another picture of a sigmoid volvulus. This is a healthy sigmoid volvulus, and you see it's nice and pink and well perfused. This is a dead sigmoid volvulus. This is necrosis as a consequence of strangulation. This patient's got a high risk of death, and if the colon perforates before they get to theatre, there is a very high risk of death. So we're going to try a little poll here. We haven't done this before, so bear with us. So these are two plain x-rays of the abdomen. Now I want you to tell me, we're going to try a straw poll, which of these is large bowel obstruction? Is it A or is it B? Okay, so don't be shy, because I can't see who's answering what. We just want to see who's going to have a go. Yeah, very good. So, of everybody that's answered, 92% have correctly identified that large bowel obstruction is shown on the right. Well done. So I'll take you through the features now of the large bowel obstruction. So firstly, large bowel obstruction, although it might seem obvious, is larger than small bowel. And if we look here at the diameter of the large bowel, you can see this will be in excess of 10 centimeters in the cecum. And the small bowel really doesn't get much bigger than 3 to 5 centimeters. So we can tell by the width of the bowel whether it's large or small. We can tell by the distribution of the bowel. So small bowel tends to be centered in loops in the middle of the abdomen, whereas the large bowel, and I appreciate this is difficult to see, is normally around the outside of the bowel. So this is cecum, transverse colon, this will be splenic flexure, and it comes down to the left. And interestingly, we can't see any air in the rectum or the sigmoid, so I suspect the level of obstruction is at the sigmoid. And then finally, if we look carefully at each of these small bowel loops, we will see that there are little valves called valvae conniventes, which go right across the bowel. You see here, and you see here. And we don't see those in the large bowel. So here, these are called haustra in the large bowel, and they only go halfway. So H for haustra, H for halfway across the bowel. So width of the bowel, distribution of the bowel, and whether or not the little valves go across the bowel, the way we determine whether this is small bowel or large bowel. Good. Thank you, everybody, for participating. Okay, so when we're thinking about bowel obstruction, we need to choose the best X-ray. Now, increasingly, we do CT, and CT is very good as to determine whether or not there are complications, and it's very good to determine the level of the obstruction. But CT is expensive, it's a very big dose of radiation, and so we don't always use CT in Oxford. So what we do in Oxford is, if we think it's small bowel obstruction, in terms of the history, the examination and the plain film, people still get plain film when they come and see us, and we're not concerned about complications, then we will give them gastrographin. So gastrographin is a radiological water-soluble contrast agent, which is swallowed, and then it goes into the small bowel. So you can see this in the central loops here. This is small bowel, all filling up with radiological contrast. And that has two purposes, really. It can be therapeutic. It's got a high osmolar content, so it'll draw fluid out of the edematous small bowel loops, and sometimes then it will be therapeutic, and the patient will then have copious diarrhea as the gastrograph passes into their colon, and we'll send them home. But it can also tell us whether or not the patient's going to get better. Because if we take the gastrographin X-ray at 6 hours after ingestion and it's still there, we're concerned this is not going to get better, and then it'll point us towards doing an operation. The people that we tend to do CTs on are the people who've got a so-called virgin abdomen. No evidence of previous surgery, adhesive small bowel obstruction unlikely, so then they're more likely to need an operation, and so then we order a CT scan. So when we're managing people with intestinal obstruction, please remember that there's a high risk of dehydration and renal failure, so everybody needs aggressive fluid resuscitation, often guided with a catheter and measuring urine output. And the definitive management of these patients is dependent on the etiology and whether or not it's been complicated by bowel ischemia or by perforation. This is a picture of normal small bowel on the right of the screen, and this is a picture of a dead small bowel. So we want to get to our patients before then, because this patient is going to need a primary bowel resection. They may go home with a stoma or an anastomosis which might leak. So who are we going to operate on immediately? We will operate immediately on patients with evidence of a closed loop obstruction on their imaging, or evidence clinically of ischemia or perforation. So those are people we're going to take straight to theatre. And we're going to operate on urgently with those people with an obstructing pathology which will not improve. So if we see a cancer which is causing a bowel obstruction in the small bowel or the large bowel, that's going nowhere, so they need an operation. If a patient has a hernia causing obstruction, the bowel will be stuck, they need an urgent operation. So, who can we manage conservatively? We will manage conservatively those with a suspected and uncomplicated adhesive small bowel obstruction. So the patient with a history of previous surgery, we're not concerned about complications, where they don't have focal tenderness, where they're systemically well, we're safe to do drip and suck, which means we aspirate the contents of their stomach and we replace the fluids with a drip. And most cases will resolve without the need for surgery. So again, I've mentioned complications as I've gone through. The complications of bowel obstruction include ischemia, bowel perforation, which can lead in the colon to fecal peritonitis. And if we do need to resect a dead bowel, people can lose a long length of their small intestine. Dehydration and renal failure are common. This is fecal peritonitis, and you can imagine this has got a high rate of mortality. So, final slide. Thank you, everybody. Learning points. Small bowel obstruction is commonly caused by adhesions or hernias, and large bowel obstruction by malignancy or volvulus. Any colicky pain in a suspected case of bowel obstruction, which becomes constant in nature or worsen movement, should be a red flag that ischemia may be developing and prompt surgery is required. A closed loop bowel obstruction is a surgical emergency. And this is an important take-home message. Large bowel obstruction commonly requires surgery. Small bowel obstruction doesn't. That's why we need to think about causes the minute we see our patients. Early recognition of those patients with impending strangulation, perforation, or ischemia is essential because early surgery will prevent the need for bowel resection. Okay, that's me. Thank you very much for joining.
I think that was very clear, and I hope there's a lot to take from the talk. We've got a bit of time for questions, and I've got a few that I hope you can try and answer.
I will try.
One of them was, how could you use a history and examination alone, or could you use a history and examination alone to differentiate between ileus or proper obstruction?
So between ileus and obstruction, so just to recap, obstruction is a mechanical or physical blockage to the intestine, and ileus has got very similar symptoms and presentation, but there's no physical blockage. It's due to an absence in peristalsis. So in terms of just examining the patient and taking a history, the most critical thing will be the situation of the patient. So it's very unusual for people to present as an emergency with an ileus, but it is a much more common thing to see in hospital. So if you're thinking about a post-operative patient, usually intestinal surgery, but sometimes even our orthopedic colleagues, cardiothoracic colleagues, intensive care colleagues will say, this patient's vomiting, they're distended, could they have a mechanical obstruction? So the more likely cause in that situation is that it's an ileus. The only way to be absolutely certain is to demonstrate that gastrographin doesn't pass through the intestine. And you can do that by giving gastrographin down, and there's sometimes some trusts through the nasogastric tube, sometimes orally. And then even with imaging, if you can demonstrate that the gastrographin isn't moving, then that's much more likely to be mechanical obstruction. Where if it passes through the bowel, then it's not a mechanical obstruction. And then often CT can be helpful as well, because they can see sometimes dilatation of the whole small bowel and large bowel, and that would suggest that there isn't a physical obstruction.
Okay, great. Related to that question, there's another where one of the attendees who remains anonymous has asked, if there is large bowel obstruction with incompetent ileocecal valve, can this be managed with an NG tube and decompression, or do you always have to use decompression through the rectum?
If somebody has an incompetent ileocecal valve and large bowel obstruction, that means that the contents of the large bowel can reflux upwards into the small bowel. The contents of the colon will never reach the stomach, but the backup of fluid that you have in the stomach and the small bowel, yes, it can be decompressed through the stomach. But we need to think again then consequently about the causes of large bowel obstruction. The causes of large bowel obstruction is it's highly likely to be a cancer. And so if they have an incompetent ileocecal valve, they don't have a closed loop obstruction, but they're still likely to need an operation. Is that helpful?
I think it is. That's pretty clear, really. And that there's another set of questions that have been asked by more than a few, and that is, why do you get a fluid redistribution in bowel obstruction, and why do patients become dehydrated?
Okay, so I think there's this concept of what's called third spacing. So the fluid goes into neither the intravascular space or the extravascular space, but is accumulated in spaces where fluid would not normally accumulate. So when the bowel becomes obstructed, then in an attempt to try and flush out the obstruction, the response of the proximal small bowel is to produce more fluid and to reabsorb less. Remember that there's 8, 10, 12 litres of fluid passing through your small bowel every day, which you never know about because it's reabsorbed. And if the small bowel is producing all of this fluid and it's not being reabsorbed, then the fluid sits in the small bowel. So that's one place where it's left. Because the small bowel is distended, it becomes edematous. So you might have a litre or two of extra fluid in the wall of the bowel. And because the bowel is very, very distended, then you get translocation fluid through the bowel. It's not working normally. And so the peritoneal cavity can become filled with fluid. So we sometimes, when we see this, when we operate on people with, for example, large bowel obstruction, as we open the abdomen, there is fluid, an abnormal amount of peritoneal fluid in the peritoneal cavity. The small bowel loops are very thick and edematous, and we can see litres of small bowel, litres of intestinal content within the small bowel. And you can see that when you pass a nasogastric tube in your patients, you might find that there's 3, 4, 5 litres of fluid coming up the stomach each day. So the loss of all this fluid can very quickly mean that your patient goes from normal renal function to acute renal function. And certainly I've seen patients within 24 hours go from admission to intensive care and require renal replacement therapy because of inadequate fluid resuscitation at the time of admission.
Thank you. Another question, if I may, Stephen, and that is, why did you say that intussusception is more common in children?
Well, the causes are slightly different. So in children, it's a more common presentation because, as I understand it, though I don't do much pediatric surgery, is you get intussusception of the terminal ileum into the cecum, and I think that's due to inflammation in pairs patches of lymphoid tissue around the terminal ileum, which then causes a thickening of the terminal ileum, and the thickening of the terminal ileum then it's almost like a bolus within the lumen, and then so the terminal ileum is intussuscepts or peristaltic along the colon. So that's not uncommon. Well, it's more so for that reason, intussusception is slightly more common in children than it is in adults, where you don't see the same pathology. In adults, the pathology is different. In adults, the pathology is almost always a tumour in the small bowel or the large bowel, and certainly we would see that sometimes with colon cancer or sometimes even large colonic polyps. So that also means that the treatment is different in children and in adults. In children, sometimes the intussusception can be reduced by gas insufflation into the colon, but in adults, because the underlying cause is usually a tumour, then we operate.
Great, thank you. There's a bit of confusion about closed loop obstruction and hernia. Yeah. And there's more than one asking as to whether an obstruction due to a hernia is always a closed loop.
Not well. I suppose the answer in surgery is never always, is it? So, in most cases, yes. My experience is that an entire bowel loop would prolapse through the hernial orifice, and then by definition, yes, it is going to be obstructed at both ends, and we do see that. And then sometimes when we take these patients to theatre and we reduce that intestinal loop, usually small bowel, we find that it's been obstructed at both ends, which is I think I did show a picture of an isolated small bowel ischemia, which is retrieved from a hernial orifice. Sometimes we see something called a Richter's hernia, which means that not all the width of the small bowel goes into the hernial orifice, and it would be easier to demonstrate that with a picture, but only part of the small bowel gets stuck, but that little knuckle can become ischemic, but not the entirety of the small bowel is actually in the hernial orifice. So they may not even have an entire small bowel obstruction, and not all the small bowel is in the hernial orifice, but certainly a Richter's hernia, because often the orifice is very tight, do have a high risk of ischemia and bowel perforation.
Great. A question about sigmoid volvulus, if I may.
Sure.
How would you manage a sigmoid volvulus, and why do you say it's extraluminal?
Well, I suppose there's nothing within the lumen, and there's nothing in the wall of the lumen which is abnormal. So I suppose, yes, it doesn't fit neatly into that classification. But in the absence of any pathology in the bowel wall or within the lumen, I think probably extraluminal is fine. And really, the management of sigmoid volvulus depends a lot on the presentation. So the people that I would operate on immediately are the people with complications. So I showed that picture of somebody with ischemia of the sigmoid, and that is usually obvious because the patient's very unwell and they would have tenderness over their sigmoid and they'd have systemic upset. That patient needs an immediate operation, and they would have what's called a Hartmann's. So we would remove the sigmoid colon and we form a colostomy and we relieve the rectum in situ. The other group in which I would operate on, but maybe not urgently, are the younger patients, maybe in their 50s or their 60s, where you know if you don't operate, then they will have recurrent problems. And I would seek to do, even without complications, I would seek to do an operation on them. In the younger patient who didn't have complications, such as ischemia, then we would remove the sigmoid, but we'd aim for what's called a primary anastomosis. We would remove the evolving sigmoid and do a primary anastomosis between the colon and the rectum. And then the final group, and I suppose this is the commonest group, are patients who present with sigmoid volvulus who are elderly. And they might come from a nursing home, and they might have, as a consequence of drugs or immobility, very slow colonic transit, and that might predispose to volvulus. Operating on such patients can be very, can risk their lives because they might have very poor post-operative outcomes. And in those patients, you can do what's called decompression. So you can pass a colonoscope into the sigmoid volvulus, aspirate the air, and by doing so, what that can do is devolve the sigmoid colon and restore it to its kind of normal anatomical position. So that can get the patient out of immediate trouble. It can also allow you to look at the mucosa of the sigmoid to see if it's ischemic or not, but it's got a very high rate of recurrence. And we do see those patients who are in their 80s or 90s who are very frail. They aren't fit enough for an operation. We have multiple admissions with surgery because we're trying to avoid major surgery, and we're trying to avoid a stoma. And those patients sometimes we're forced, I suppose, to consider the fourth option, which is to form a stoma just by bringing the evolving sigmoid out onto the wall of the tummy, not doing a resection, and sending the patient home essentially with a loop colostomy to try and prevent further recurrences. So does that answer the question, Mike?
I think it does. And I wish we could continue because you've got so much more to add. But we are out of time, Stephen. Thank you very much.
It's been an absolute pleasure, Mike. Thank you for asking me.
Thank you.